Okay. I think we'll get started regardless. Hi, I'm Lauren Bohm. I'm one of the pediatric otolaryngologists at Michigan Medicine. Thank you very much for having me today to talk about pediatric facial fractures. I'm trying to make this talk as interactive as possible, so I did include some poll everywhere responses. So if you are live on and you have a smart device, you can navigate to the website shown on the first slide, pollev.com/ my first name minus the N, Laure, and then last name Bohm, BOHM 979. That will give you access to the poll everywhere responses that'll be throughout the talk. It's meant to be interactive, so feel free to either unmute yourself and ask questions. I welcome any interruptions. That's totally fine. Also, I do have the chat open, so as things come along, I'll be sure to answer, or if not, we'll get to them all at the end of the talk. So I do want to encourage participation. Hope you all are staying healthy and safe out there. All right, here we go. Maybe. Okay, so just to test out the poll everywhere for anyone that is live online right now and was able to get to that website, if you can answer the first question about your role, just to get a sense of who is on, any PGY levels, medical students, or fellow faculty. And I realize there's only a few, so if responses are not coming through, that's all right, we'll move on. And anyone who joins late, we can reiterate some instructions. Okay. Similarly, the second question was just asking where people are coming from today. I know from prior experience looking at this lecture series has had a pretty great turnout response rate throughout the country, so I'm glad we have this forum to keep disseminating some knowledge and doing some didactics. All right, well, moving on to today's talk. So the outline today, within the next hour, we'll review some anatomy. I think I would be remiss if we didn't talk a little bit about anatomy and why it's pertinent to pediatric facial fractures in particular, because it does influence fracture patterns and prevalence, which leads us to the next point, which is the epidemiology of pediatric facial fractures. We'll spend the bulk of our time going through treatment principles. So we'll go through site-specific fracture management and incorporate some case examples, so that way it's more memorable and pertinent to your learning experience. All right, so just to start off, this is actually a patient that I took care of, a 4-year-old who presented to the ED after being involved in a motor vehicle accident, had this mandible fracture shown here on the left on this axial CT scan, and then on the right on this 3D reconstruction. I just posed this because to get you thinking about how you would potentially repair this fracture, or if you would at all, how you would manage a fracture in someone this age. And what special considerations would you take into account compared to, let's say, an adult who presented with a similar fracture, because there are some things unique about kids, both in terms of anatomy and management. All right, which brings us to our first point about developmental anatomy. So for anyone on the line or who just recently joined this website, Poll Everywhere, if you have a smart device and can navigate to that website, then you can participate in the polls. But feel free to either shout out or write some anatomic differences that you've experienced or know about in pediatric patients compared to adults. When I previously given this lecture, people have mentioned things like teeth. I think that's definitely one aspect that can be lead to a little bit of uncertainty with regard to repairs and facial fractures because of mixed dentition states and tooth buds that are still erupting that we have to be careful for. There are also a number of other differences that we'll go through here shortly. All right, so just in general, we'll start with the pediatric facial skeletal structure. So I like this figure because it does demonstrate nicely how that changes over time as we grow from a neonate up to an adult. In reality, what we're really talking about is the cranial-facial ratio. So in neonates, the cranial-facial ratio approximates 8:1. So the cranium itself is really large and comprises most of the head area. And so it's really more prone to injury. And neonates, the face, midface, and mandible take a more retruded position. But as we grow over time, that ratio changes. To the time we're adult, it approximates about 2.5:1. And the midface and mandible become more prominent. They move into a more anterior and inferior position. And so that increases the incidence of facial fractures as opposed to cranial fractures as we age. The other obvious difference is sinus pneumatization. So some sinuses are present at birth, but a lot, some aren't and develop over time, and oftentimes don't reach full development until prepubescent, adolescent, or even adult years, as shown in the figure over on the left. And so that the lack of sinus pneumatization actually confers some strength to the facial skeleton, which provides stabilization against fractures. Tooth buds, I already alluded to this. They are present both in the maxilla and mandible of children. We'll go through a little bit about dentition states and approximate ages when you can anticipate primary dentition and secondary dentition will come in. And so this is always a consideration when we're thinking about things like maxillomandibular fixation, MMF, because there are some unique strategies in kids that we do that. Plate placement, so for a typical open reduction internal fixation ORIF, we have to be cognizant about those tooth buds during plate placement so we don't damage any potentially erupting teeth. All right, the other big difference is in actually the bone quality itself. So pediatric bones are more compliant. There is some truth to the notion that they bend and don't break when they fall. So they have a higher ratio of cancellous to cortical bone. The suture lines are more plastic. The periosteum is more substantial. And so all of these factors help add up to the increased rate of green stick fractures that we see in children compared to true through and through displaced fractures. And so usually green stick fractures are more common in minimal displacement, which also helps, is one of the reasons why we oftentimes get away with more conservative management of facial fractures in pediatric patients. Lastly, these chubby cheeks, we've all seen them. They really correspond to both superficial fat and localized fat compartments. There's more of both of those in children. And so that essentially acts like a pillow and protects the underlying facial structure of kids. And so in general, that makes facial fractures less common in this population than some of our adult counterparts. So exactly how common are they? All right, one more poll everywhere response if anyone is able to get on the website. Again, for those of you who just joined, it's up at the top, pollev.com/Lori E. Bohm 979. But if you had to guess, out of all facial fractures that come through in all age groups, what percentage is represented by pediatric facial fractures? How common do you think they are? Even if you don't respond on the website, but just think in your head, if you think they're less than 1%, 1 to 5%, 5 to 10%, 15 to 25, or greater than 25 in your own experience on call, or what you've seen or read about. 5 to 15 looks like the most popular response, which is correct. You're spot on. So it depends on obviously the literature source, but in general, most people will quote a prevalence somewhere between 5 and 15% for pediatric facial fractures. And these are really pretty rare in children less than 5 years of age. More common in males. And one of the big drive home points I'd like to emphasize is that they are more commonly associated with other injuries. And so unlike adults, an isolated facial fracture is pretty rare, just given the force that's required for the facial fractures. Concomitant skull injuries, systemic injuries do happen. And so having multidisciplinary management with the trauma team is important. You may be co-managing these patients with your neurosurgery colleagues or other colleagues, and just keep a high end of suspicion for other potential injuries should you be seeing someone with a facial fracture. Things like C-spine precautions, be sure to maintain. In kids, you obviously, younger children, the mechanism typically is more low velocity injuries, so a trip and fall accident, let's say, versus older children, as we can see, yes, in the next slide. This is from a retrospective review of almost 300 pediatric facial fractures, and it really just points out that the younger group, as shown here, the 0 to 5-year-old range, most of their facial fractures were caused by falls, not surprisingly, as opposed to here, road traffic accidents. That's what RTA stands for. Sports or violence are more common in the older age groups. From that same study, this just goes by site where the location of the fractures occurred. And as you see here, skull fractures were more prevalent than facial fractures. All right, so moving away from skull, moving on to facial fractures, focusing on them themselves. If you had to guess which fracture substates are more common, what would you say? So if you could arrange these options from most common to least common, what would you guess? And there is some variance in the literature too, I'll say that. Anyone want to take a stab at it? It's not too disparate from adults. Nice. Nasal, orbital, mandible, maxilla. Things are shifting around a little bit. We'll give you another minute. Got a few ties. It looks like maxillary mandible being first and orbital nasal next. So this is according to one study that was looking at the National Trauma Bank data for over a 5-year period and analyzing almost 13,000 children or facial fractures. And these were their sites and their representative percentages. That being said, I do have a caveat in that probably isolated nasal fractures are not always presenting to medical care. I know that from my own practice, and you've probably seen similar things too. So my suspicion is that nasal fractures are underrepresented in studies like this, where we're looking at hospital records to analyze our data, and likely are probably the most common site of injury. Follow closely or along with mandible fractures, maxillary and orbital. And we'll talk about each of these sites. Any questions before we move on? All right, so treatment specific. As I alluded to a little bit earlier, it's important to remember the context of these of the children when they come in with facial fractures. So I need to mention just basic ATLS management. We think about all of that when patients come to the trauma bay, and sometimes we're not even consulted until some of this initial workup has been done. But keeping in mind, being cognizant about C-spine precautions if there's any suspected injury. Sometimes patients are not able to be cleared prior to surgical treatment, and so maintaining C-spine precautions with sandbags or a brace of some sort in the operating room may be something that you have to work around. And it's good to trial those practices, and so you become comfortable with that management. Be aware about the high incidence of concomitant intracranial injuries. ED for any open wounds will verify tetanus status, and so usually we have to be also cognizant of that. History and physical exam can be difficult on children who've undergone or experienced traumatic injury, and so Oftentimes, if there are caregivers that were with them or accompanied into the emergency room, you may very well be getting all of your history from a caregiver or even a witness. Information from EMS can be helpful. Your physical exam will go through a bit site by site about important things to look for and make sure that you assess and are documenting. And then lastly, really, the CAT scan has become the imaging modality of choice for facial trauma. It's really supplanted any type of plain radiographs, all those views that you may have heard of in the past, Waters view, Townshend, all those things. This is really now gold standard treatment. And so I suspect that is likely what you'll be getting at most institutions if you're concerned about facial fracture. All right, so just general treatment principles in children. We all know they're incredibly quick healers, and so this does influence our time frame for taking some of these things to the operating room, and when we can anticipate stability. So it may influence our return to school or sport recommendations. We talked a little bit about the fact that most of these fractures tend to be, or they have a higher percentage that are green sticker or non-displaced, and so conservative management is more common than with adults typically. And then there's a lot in the literature about the potential for growth disruption. So depending on the age of the child that presents, they potentially have a lot of growing left to do in their face, and depending on where the facial fracture is, it may span some of those suture lines. And so if you are going to be doing any type of permanent plating system or any type of plating system, what are the pros and cons of using titanium versus something resorbable? And what impact does it really have on facial growth? We'll talk about all those things. We'll start with nasal fractures. Another take-home point I want to emphasize is that the prevalence of septal hematoma is higher in children who present with nasal fractures than adults. So that's something to be aware of and really make sure you're assessing for in kids who come through when you suspect a nasal fracture. Kids that have them, most commonly, the most common presenting symptom, about 95%, will have symptoms of nasal obstruction. So that's something to ask for and look for. But you can also have pain, particularly pain out of proportion to the injury site. Should that develop into an abscess, you may have other more systemic signs of infection like fevers. So it's always important to evaluate facial or nasal fractures after the edema resolves. Oftentimes that's when we get our most useful clinical exam, because then we can really assess for any new cosmetic changes. Is the dorsum still aligned in the midline? Are things shifted or impacted? And are there any new functional deficits? So are they having more symptoms of nasal congestion during the day? I will also usually ask a caregiver about new onset snoring if they've noticed. Some of that is common with the edema itself, but as the edema subsides, they should be starting to return towards their previous baseline. And then treatment options. So for an immediate period, we treat with closed nasal reduction. In kids, this usually needs to be done in the operating room under general sedation or general anesthesia, just because of comfort levels. I've not yet attempted one of these in a younger child or in a child awake. The time frame is something to note. So like I mentioned, kids heal faster. So really, probably, especially in younger children, this should be performed within a week. You can still wait those initial couple of days until some of the edema resolves for your exam, but then doing this in an expedited fashion will allow you a better chance at repositioning those nasal bones and having a better cosmetic outcome ultimately and functional outcome. All right, and closed nasal reduction, there are a number of tools available for us. The Ash, Walsham, and forceps, the Boy's elevator, but they're all used essentially intranasally to reposition those nasal bones. And again, in kids, this is usually performed in an operating room setting, plus or minus a cast over the dorsum at the end to help support your reduction and minimize postoperative secondary edema. All right, so let's say you're on call and you are contacted by the ED because an 8-year-old presents 5 days after being kneed in the nose. If you feel comfortable unmuting yourself and you have some other questions about this patient for the emergency room physician that you're speaking with, feel free to shout them out or put them in the chat. Otherwise, I'll give you some of that information. So this 8-year-old, in addition to complaining of vision changes, great, keep coming. So you're right to think about, even if, let's say, the reason for consult is suspicion for a nasal fracture, really still doing a complete head and neck exam, and it's not uncommon for nasal fractures to go hand in hand with other facial fractures. So thinking about, yes, is the orbit affected or anything else is important. And that may dictate whether you recommend any type of imaging versus not if you really think it's just an isolated nasal fracture. So yes, asking about vision changes, anosmia, always ask about loss of consciousness. It's a helpful mechanism of injury. In this case, we know the kid was kneed in the nose and did not lose consciousness. It is really still stuffy, 5 days. And mom notes that actually, in addition to the congestion, she has appreciated some snoring. He used to snore lightly prior to the injury, but afterwards it's really been more evident even through a closed door. And is having some nasal pain too. It really hasn't subsided at all since the injury 5 days ago like she would have expected. So after you collect your vitals and do your full head and neck exam, this is one of your findings on anterior rhinoscopy. So you can see here the bulge in the septum bilaterally in this case. That really is representative of some type of fluid collection, whether that be hematoma, abscess, something there. Typically, you would not see that mucoperichondrium so lifted off of the, I gave it away, off of the septum like that. I have gotten the question before, how do you differentiate this for sure? A fluid collection versus just edema, because yes, the inside of the nose can be quite edematous after a similar type of injury. One recommendation is to palpate. So oftentimes I'll use gloved fingers and try to palpate as long as they are tolerant of it and not too tender, but that really gives me a sense of what's going on. Other options, you could try a topical decongestant and see edema should decrease with topical decongestant as opposed to a fluid collection, which would not. In this case, the ED already was helpful and had just gotten CAT scan prior to our arrival, and so you have that to review as well. Just looking at this, so this is an axial CT scan. We're at about the level of the maxilla. You can see here, it's contrast enhanced. And what I want you to really focus on is up in the nasal vestibule here. You can see some patency of that right nostril. Left side looks pretty occluded, and then you see this large hypodense fluid collection that appears rim enhancing. And as we scroll through, you'll see it's quite large. It actually extends pretty far back, even more than we were able to appreciate on our physical exam initially. I don't see any other concomitant facial fractures. It's always important to have the best piece of advice I have for both your physical exam and your imaging review is really try to make it as systematic as possible. So that way, if you're always doing things the same way, you're less likely to miss something in the future. So oftentimes I'll start either from the top or the bottom and really look through each subsite. Okay, mandible, let's look here, let's up through the condyles. I'll look at the maxilla, then for nasal fractures, any mid-face fractures like a ZMC, make sure to check for orbital floor on both sagittal and coronal views. That's another good point, is to look through all the different cuts that are available for you. All right, so now we have suspicion that there may be a septal abscess or hematoma. In this case, the kid was also mildly febrile, so our suspicion for abscess is increased. We feel that this needs drainage, but how would you approach this? what would you do intraoperatively? Would you close this? Would you do anything to try to continue to drain this area? Would you send cultures? And even if so, what would you use as for antibiotic coverage prior to any culture results? So just as quick review, oftentimes when we're trying to access the septum, let's say for a septoplasty, there's two major incisions that we often think about, and these are also work well for hematoma drainage. So hemitransfixion or transfixion incision at the caudal end of the septum versus Achillean, which is a little further posterior. If there really is bilateral fluid collections, then oftentimes if I'm making bilateral incisions, I'll stagger those to try to prevent cartilage necrosis in between. What else? I think needle aspiration is most really insufficient for good drainage and to prevent fluid reaccumulation because of how quickly that mucosa will close. And so doing a type of a formal IND is appropriate. And in kids, that's, again, is usually under general anesthesia. Take cultures, irrigate out the area. And then there's lots in the literature about closure, drain placement. And and I don't know that we have enough information to definitively say that there's one right answer. So in my experience, drain placement's a great idea. It continues to let any purulence egress or hematoma egress so things don't reaccumulate on you. Practically speaking, in a kid, I've tried all sorts of things, rubber bands, Penrose, having something dangling out of the front of the nose and trying to secure that in a kid and keep it in for a period of time is tough. Not many are going to be super tolerant for that. And so other options, people will talk about packs or splinting, which is great because they co-op the flaps. Splints in my experience has also been a little bit difficult because it can obscure your subsequent physical exam. So if you have any concerns in the postoperative period, let's say they don't seem to be getting better, it's really hard to assess that area without removing the splints altogether. And whatever you do, ideally you want to co-op those flaps so that way your septal cartilage still gets adequate blood supply and you don't get necrosis and a saddle nose deformity down the road, which may happen anyway, just given the duration of the infection in this case. But you also want to still allow egress of any residual infection or hematoma. So what I've found to be helpful is just do a really loose quilting suture, particularly more posterior away from my incision. So keeping the incision open for drainage, but still co-opting the flaps to some degree after a really thorough washout has been helpful. Antibiotic coverage, we typically just cover our usual upper airway digestive bacteria, so covering gram-positives and anaerobes. Something like augmentin or clindamycin is usually a good first choice. And then if you have culture-specific data, all the better. All right, so moving along, let's get scooting. Mandible fractures. So this pyramid diagram is just to show that far and away the most common location for mandible fractures in kids are the condyles, which makes sense if you think about it. Those trip and fall accidents put some pressure up here on your condyles. Those are followed by symphysis or parasymphysial fractures. Just to briefly review some mandible subsites for those of you who haven't had a lot of experience working with fractures or reconstruction. So condyle, we're talking way up here by the TMJ, followed by the vertical ramus, which makes a turn at the angle. You have the body of the mandible, followed by the parasymphysis, which is just in the parasagittal plane, and symphysis really refers to the midline. Condylar fractures, you may have heard sometimes some things thrown around like a low condylar fracture or condylar neck fracture. And what is all this different terminology, and why do we feel the need to subdivide this specific site? So the head really of the condyle is referring to that most superior portion, as you can see here. The neck extends anything from below that to your sigmoid notch is what we refer to a neck. And then even below that, along the posterior part of the ramus, is still considered a subcondylar fracture, extending from the sigmoid notch down to the mandibular foramen, which is located on the internal surface of the mandible, approximately in this location. why this is even pertinent is basically for reconstruction. So if you have to put a plate on this, exposure can be difficult, and the lower it is, oftentimes the more feasible plate placement is. And so that's why some of this terminology has come to be. Things to consider, we do have growth centers in our condyles. And so we are cognizant of that, and there is an emphasis on early mobility. So if you do something like MMF, these kids are particularly prone to ankylosis if they are kept in rigid MMF too long. And so really early mobilization within 7-10 days, or definitely before 2 weeks, is important to prevent those complications should you pursue MMF. That being said, for kids with pretty normal occlusion and mobility, no obvious trismus on exam, a soft diet, conservative management with a soft diet is usually sufficient. If there is some degree of mobility or reported malocclusion, and you can assess that on your exam as well, then MMF or Maxillomandibular Fixation is a good option, and really reserving ORIF or plating for significantly displaced condylar fractures. All right, so this brings us to our next point about MMF in children. This is oftentimes a little bit of a sticking point because these aren't that common, so you don't deal with it that often. This is where teeth become a consideration. So just for your information, when we think about primary and secondary dentition, usually primary dentition teeth start erupting around 6 months of age. Kids oftentimes have stable primary dentition about age 2 to 5. So that's, prior to that, teeth are still coming in. And then usually around age 5, so kindergarten, first grade, that's when you start losing teeth. And so between age 6 and 12-ish, you'll have this mixed dentition state where you have some primary dentition, you'll have some secondary dentition, you'll have loose teeth, and that can be difficult for deciding on MMF strategies. And then lastly, anyone over 12 usually has mostly secondary dentition by that point, and you can treat them similar to adult. But what are some things in any of those age ranges that you've seen or heard about as options for MMF? Give you a minute more if anyone wants to type in anything on the poll everywhere. Okay. So in kids, there are a number of options available to us. So just like adult management, probably one of the more common things that you'll come across are arch bars or Eric arch bars. These are basically prefabricated bars that we put on the maxilla and mandible, and then secure with circumdental wires. They have these little hooks on both of them, so you have to make sure you orient them the right way, so that way the hooks are facing away from each other. But then those hooks can be used either for wiring. Usually what you may have heard of fish wires, where we take 24, 26 gauge wire, make it into the shape of a fish, and can then tighten that down to really secure the maxilla to the mandible in the relationship that we want. Or elastic, sometimes people will start with formal wiring and then gradually increase mobilization by switching to different strength elastic bands, and eventually nothing. There's also something called a Risdon cable, which is used in pediatrics, which is just essentially just like your own version of a homemade arch bar. So you take 2 larger gauge wires, twist them together. It's a bit more malleable, lower profile, can contour to the kid's teeth, but still secured with circumdental wires in a similar fashion. There are hybrid MMF, these rapid fixation hybrid MMF systems that are now available from a number of different companies, but they are secured with screws, but still give you the same options for wiring or rubber banding. These, it's important to note, because of the screws, and we worry about tooth buds, these are really approved in kids 12 years and up. So those that have secondary dentition that we would otherwise treat like adults. For our really young or edentulous children, acrylic splints are a nice option. So you may have seen these. Here's one that we created with assistance of some of our dental colleagues, but typically dentists and OMFS are pretty familiar with these and oftentimes have systems in place that they can make these with short turnaround. So this is just a lingually placed acrylic splint that, for a mandible fracture. These can be secured with screws, the wires, circumdental wires, or occasionally if really you have an edentulous patient, you can put a wire on the entire mandible, so circummandibular wires, watching out for that mental nerve, or even transnasal through the piriform aperture. So there's different ways, different methods of skeletal suspension you can use to keep something like this in place. And it really just keeps those bone fragments in alignment while things are healing. So let's say our condylar fracture is really displaced and we do need to go in and plate it. There's a number of different approaches and pros and cons to each. A lot of it oftentimes depends on the surgeon's comfort, but transorally you can use a retromolar trigone type incision right near that area. It's a vestibular incision as shown in the upper left corner, with or without endoscopy for assistance. You have a retromandibular approach up here as shown in the center, or pre-auricular approach. Those actually give you pretty similar exposure, but slightly different scars and cosmesis compared to the submandibular and facelift incisions as shown on the bottom row, respectively. But all different ways you can access this area. In my experience, it is, depending on how high that fracture is, it can still be a bit of a challenge to get exposure and to get screw placement. Ideally, at least 2 screws on each side of the fracture line. All right, so our second most common fracture site, symphysis and parasymphysis fractures, grouping those together. Main considerations here are that tooth buds are close by, particularly the canine tooth is actually located really close to the inferior border of the mandible and can have very thin bone, I mean a matter of a millimeter or 2 on top of it. So something to be mindful of while you're doing plate placements, in addition to the mental nerve that we always watch for in these locations. Plate fixation, trying to keep it close to that inferior border and really using monocortical screws is helpful. The removal of plates is controversial. So some sources will advocate for removal because of the potential for growth restriction, although I think more recent studies have shown that may not be as much of a concern as we originally thought. But regardless, that concern has really brought about the increased use of resorbable plating systems with these different types of copolymer like PLA, PLG. And so these are, resorbable plates are basically a plate that you have to heat up so that way you can warm it and then contour it to the patient's bone. They have similar functional outcomes over the long-term studies have shown. Similar flexibility, similar strength, although that's always been the concern. To get a similar strength to titanium equivalents, a lot of times these plates are bulkier, and so they may be more palpable. They have full strength over that first 4 to 6 weeks, which is usually sufficient for pediatric facial fractures. Like we said, mentioned, they heal faster, and then really start to absorb, usually in the order of 6 to 18 months, although it could potentially stick around a little bit longer. There's a pretty well described inflammatory response that some of these plate materials can incite during the resorption process. So some swelling may be expected. It's something to counsel your patients about. The thing to know about resorbable plates is that for facial reconstruction, they are FDA approved for non-load bearing areas. So really mandible is not considered one of those subsites. They got most of their use in craniosynostosis, like cranial vault remodel. I think that's primarily where they were used initially, and some of that same literature has traversed over to facial fracture management. But they're good for mid-face fractures, in particular a non-load bearing area. There's a Cochrane review that's a bit old now, but the most recent one basically concluded that there's insufficient evidence to determine whether they're superior to titanium plate. So I've used them before for sure. I personally have not used them. I've only used them in non-load bearing sites. And they work well. They do require tapping, and they can be a little bit trickier to place, just given that you have to mold them and melt the screws into them essentially. But they do work pretty well, and then you don't have to have any worries about removing the plates. Plate removal, I've done in kids. Let's say I had one that required a big, really comminuted mandible fracture that required a recon bar, and it was in a younger kid, less than 10 years of age. That I felt like did need to come out given the substantial size of the plate in the younger age of the kid. But otherwise, the recommendation is really to weigh it on an individual basis, because this will require second anesthesia. So what is their anesthetic risk? It'll require second surgery, another incision and healing period. And so some people will, if for smaller plates and older age groups, will either not remove it or really reserve it for symptomatic patients that are having difficulty with the plates, but otherwise we'll keep them in place, which I've done with some of the older kids. Oh, sorry, we're not gonna upload later. Upload software. All right, and this just shows in animal studies, titanium versus resorbable plates have similar long-term outcomes, although maybe some faster healing in immediate healing in the titanium group initially. Smaller case series really show a lack of complications from the use of resorbable plates. In general, they seem to be pretty safe and efficacious. All right, we'll go quickly through body and angle fractures since these are less common. And majority are green sticker non-displaced. So similar management, you'll notice a pattern here. Soft diet for minimally for non-displaced, MMF for minimally displaced, and really reserving ORIF for significant displacement comminution. Or if you try to close reduces, oftentimes, we'll see if we can get by with just MMF, and if it's really not working, then we'll need to open up that fracture site. Immobilization is a little bit difficult just because of the location. So it's really, fractures location are not amenable to splint placement. Dentoalveolar fractures, I'm just going to briefly mention because they are common. So a tooth that falls out or a dental avulsion. Technically, if it's a primary dentition, replacement's not necessary. But it can be nice because it helps preserve that gap for secondary dentition to erupt. If you do have an adult tooth that falls out, and someone calls you, let's say on call, you can advise your patient, ideally if they can just put it back into place, so kind of put it in the socket, that's great, and maintain some viability of that tooth. Depending on the age and cognitive status, we obviously recommend that in kids or people that you're not worried about aspiration risks. Other methods for transport include putting in some milk or saline. Regardless, you want to have that reimplanted within an hour or two, so it is a bit of an emergency situation to try to preserve the viability of that tooth. Alveolar fractures, so ones that really just go through the gum, kind of the gum line, oftentimes can be managed just with a splint or arch bar. I've used some like thermoplast or aquaplast, some type of casting material. Oftentimes we'll use over the dorsum for, let's say, a closed nasal reduction or open septal rhinoplasty. I've used it in this type of scenario before as a splint type material that you can mold to the teeth. Also has holes that can help with some circumdental wiring. But usually some type of splint just to maintain that proper alignment and contour for a couple of weeks is good. Rarely is ORIF necessary, and if you do, you want to minimize your periosteal elevation because you're trying to preserve that stability. So going back to our original mandible fracture, this is that 4-year-old who was in a motor vehicle accident and came in with this fracture as seen on this axial CT. Knowing what you know now, would anyone change management compared to what you were thinking before? Okay, yeah, I agree. I would still proceed with ORIF given how displaced this fracture is And then just keeping in mind some of those considerations about tooth buds and other things like we were talking about. I should mention for ORIF, you know, you do want to have that inferior plate and then a more superior tension band for something like this. Okay, so for orbital fractures, your physical exam is important, and really doing a comprehensive physical exam. So not only just looking at the soft tissues around the eye, but basically looking at a basic exam of the globe integrity. Extraocular movement exam is very important to look for entrapment. So you can have the patient look in all cardinal directions if they're awake and alert. Otherwise, force duction testing with like a 0.5 forcep or something is necessary to make sure that the globe can move in all directions. Some basic visual field and gross visual acuity testing, a pupillary response with your pen light. And then another key is checking for infraorbital hypoesthesia, so V2 numbness that can occur, as in orbital floor fractures can often extend through that infraorbital foramen and give you numbness there. Kids, young kids, oftentimes actually have orbital roof fractures as opposed to older kids are more similar to our adult population. Once that maxillary sinus is pneumatized and thin the floor, they're more prone to orbital floor fractures are more common. Another thing to take from this lecture is that entrapment is higher in kids because of the increased rate of trapdoor fractures. So similar to other locations, orbital floor is prone to green sticking. And so if you get a fracture, it can often snap back into place. And so in doing so, it can grab some of that inferior rectus muscle and cause entrapment. And in kids, they can have something called a white eye blowout fracture. You may have come across that terminology before, but basically that just means you may not see a whole lot of soft tissue findings with a fracture, orbital floor fracture that's causing entrapment. So adults oftentimes have more reliable presentation with periorbital edema and ecchymosis and subconjunctival injection or hemorrhage. Kids sometimes they can look surprisingly good and their exam can be relatively normal unless you do that extraocular movement test as seen in the picture in the lower right. So that right eye is not elevating superiorly like you would anticipate with upward gaze. Nausea and vomiting can be a sign of entrapment as well. Orbital roof fracture is pretty rare, more common in younger kids, but really oftentimes similar to the floor involving the infraorbital foramen, the roof can involve the supraorbital foramen as the area of weakness. And don't typically require treatment unless there's a cosmetic deformity, so a big depression or displacement, any ocular intracranial compromise, in which case ORIF, either through an existing laceration or a different incision site, a different incision is appropriate for these fractures. I think we're all probably more familiar with orbital floor. Why would you consider repairing an orbital floor fracture? Has anyone heard of any common indications? That'll be one thing on your physical exam, or history. Diplopia, so double vision, entrapment, which mentioned that a bit. Defect greater than 2 centimeters. Good. These are great. Thanks, guys. Right, so out of all orbital fractures, floors most commonly require repair. More emergent indications would be entrapment because we don't want that muscle to necrose and then subsequently fibrose and have permanent gaze restrictions that would ultimately lead to diplopia if not corrected. There's also something called the oculocardiac reflex. So sometimes it's going to present with bradycardia, given some of the neural pathways. And that would be another reason for emergent repair. Inophthalmos is where when we change the size of the bony orbit, the globe can become displaced within the orbit. And so If it's posteriorly displaced or hypoglobus inferiorly displaced, that will ultimately, if not corrected, give you diplopia. And then lastly, sometimes the hypoglobus or endophthalmos is not immediately apparent. And so we try to predict who's going to develop that once the edema resolves. And there's a bunch of papers, really literature more in the adult world, but applicable to kids, to estimate the amount of involvement of the floor. So if it's a large defect, someone mentioned over 2 centimeters, or more than 50% of the floor appears involved, like let's say on your sagittal scan, then it's more predictive that they're going to have issues, and so repair is indicated. Great, lots of approaches, both transcutaneous and transconj. To get to the orbital floor for plate placement, you can also actually go transantrally with endoscopic guidance through that maxillary sinus to put a plate there on top of the bony remnant. Interest of time, we're going to move on to ZMC fractures, or tripod fractures as they're more commonly known, although it's a bit of a misnomer because they're really more of a tetrapod fracture since they do involve 4 suture sites. So you have your zygomatical frontal or ZF suture, zygomaticomaxillary, deep to that your zygomatical sphenoidal, and then your zygomatical temporal right here along your actual zygomatic arch. And it's that piece that is prone to being fractured. More common in adolescents who have pneumatized sinuses, treated similar to adults. So oftentimes I want to get a plate on at least 2 of those, across 2 of those fracture areas, preferably 3 if I can. Can use bioabsorbable plates. This is a non-load bearing area. Titanium also is an option. I will usually use a keen approach, so using like a gingival labial incision is a nice approach. There's also Gillies and other a temporal incision, other ways to get to these areas too. And really would repair if there is significant displacement causing cosmetic issues, any concerns about the eyes or coronoid impingement. So our next patient is 15. Similarly, he collided with a friend, although this time it was a shoulder, while he was playing soccer a couple days ago. Now coming to the ED when you're consulted. They also obtained a scan before you arrived, just for your review. So again, looking at this axial CT scan, non-contrast this time. Again, the patient's left side in this contour. First of all, you can tell there's still some soft tissue swelling because even though it happened a number of days ago, it looks like externally things still look pretty good, but if you can tell that that bone is really posterior displaced on the face of the maxilla. Not quite impinging on the coronoid here, but something that we always watch out for with zygomatic fractures. You can see that the arch, comparing symmetry from side to side, is different. There's our displacement extending near our infraorbital foramen. There's our ZF suture up here. It's fractured. We can see that again on coronals view and sagittal. And some 3D recons. One thing to note with ZMC fractures, during the repair, after I've disimpacted the fracture and got it back into alignment and plated, always go back and check your orbital floor, because these very commonly go hand in hand. You can imagine this part gets crunched in, your floor can buckle too. And while this is impacted or displaced, it can make the floor fracture look pretty insignificant. And then after we get everything lined up how we want to, sometimes that floor fracture is actually a bit larger than we anticipated. And so then we worry about the development of endophthalmos and eventual diplopia. So while you're already there, oftentimes it's a convenient time, if you think that's going to be the case, to slip in an orbital floor plate as well. And you can see here, just like we talked about, it goes through that infraorbital frame in that area of weakness. And so when you put plate placement, just be sure to keep the plate from impinging on that nerve. Got lots of 3D recon, but you can see how that affects your bony orbital rim too there, and the symmetry of your zygomatic arch. This one, I don't have any postoperative photos, but we did go ahead and plate that ORIF through a keen intraoral incision with good fracture reduction. All right, that is all I have. I appreciate all your attention and the time. We do have a few minutes left, a couple minutes, so if people have questions, want to put in the chat or shout out, feel free, and then I'll make way for the next lecture.
That was great, thank you.
You're welcome.
How many pediatric mandible fractures are you all doing roughly?
It's a good question. We do share some trauma call with our facial plastics and OMFS colleagues, so it's every 3rd week. I would say I probably get 5-10 a year, depending.
Okay. Do you find that you all end up doing them, or does plastics have like craniofacial people that, because I feel like with peds, it's sort of a up for grabs.
It really depends on the week. That's how our call schedule is set up. And so if it comes in while we're on call, then we take care of it. But I think there's representatives in every specialty that's comfortable with it, or at least a few faculty members in each specialty that are comfortable with it, and have a pretty collegial relationship. So like I mentioned, that lingual splint, I was able to have some of our OMFS colleagues help out with the creation of the splint for subsequent placement, which is nice. Yeah.
Well, thanks, that was really great. I think it's always a topic it's hard to cover. We don't see it as much, but every now and then, so really good topic.
All right. Again, thanks very much. My email is also there, so if you have questions that you think of later or just want to reach out, feel free. Okay?
Thanks.
All right, thank you. Take care.